Lungs are one of the most important organs of our body, allowing us to inhale air for our metabolic needs. Unfortunately, air is not all we inhale. Many bacteria also gain entry into our respiratory tract, thus posing a significant challenge to our immune systems. When free-flowing planktonic forms of bacteria like Staphylococci, Streptococci, Haemophilus influenzae, and Pseudomonas find living conditions such as epithelial surface, they adhere to the host surfaces by using weak bonds like van der Waals forces. The bacterium tries to loosen the epithelial junction and at the same time exudes extracellular polymeric gel-like substance. This polymeric gel matrix is made of complex sugars and provides them protection from host defense mechanisms and environment, facilitates attachment, and also aids in trapping the nutrients from outside. The bacterium gets nourished and starts multiplying within the safe environment provided by the gel and produces daughter bacterium. These daughter cells produce their own glycocalyx and start communicating with each other, a process known as quorum sensing. Within a few days, more bacteria are attracted and the colony increases in size. Subsequently, this complex aggregate of microorganisms acts as a single complex entity called biofilm. The biofilm forming bacteria release inflammatory mediators such as cytokines, which bring about the inflammation of the epithelial cells. The situation worsens further when the bacteria invade through the epithelial junction and affect the underlying tissues. These biofilms also provide a safe shelter to other free-flowing bacteria, protecting them from the action of many commonly used antibacterials. Many commonly used antibiotics fail to penetrate the biofilms and are unable to exert any effect on the bacteria cocooned safely within the biofilm. Sometimes, strips of biofilm or a few superficial bacteria strike free of the colony and relocate to other sites, thus expanding the infection. Chlarytromycin, a macrolide antibiotic, comes to the rescue and has significant impact on biofilm formation and prevents the progression of disease in the lungs. As it strikes at the biofilm, it smoothly penetrates the previously non-breachable biofilm. Chlarytromycin inhibits the production of glycolates, a major component of biofilm. It further decreases alginate, hexose, and other polysaccharides that make up the gel matrix of the biofilm. Once Chlarytromycin penetrates the biofilm, other commonly used antibiotics such as aminoglycosides, cephalosporin, and beta-lactam, which were previously ineffective, can also enter the biofilm and exert their antibacterial action. It impairs the motility of the bacteria and subsequently destroys the shielded pathogens. The phagocytic activity of leukocytes is also increased. Chlarytromycin inhibits the expression of cytokines like interleukin-2 and 6 and ICAM-1, thus inhibiting the inflammatory response. Further, inhibition of MUC5AC results in decrease in mucus secretion. Eventually, all the biofilm starts withering away and the host becomes free of infection. Clinical guidelines recommend macrolides such as Chlarytromycin as the first-line agent in community-acquired pneumonia. Chlarytromycin ensures wide antibacterial coverage, including atypical pathogens. and achieves high tissue concentration in the extracellular fluid. It favorably modifies inflammatory parameters and exerts beneficial effects beyond antibacterial action. Use of Chlarytromycin enhances the activity of concomitantly used antibiotics by destroying the biofilm and prevents further development of biofilm. This wide range of actions of Chlarytromycin used singly and in combination provides physicians with another potent weapon in the fight against resistant infections.